I'm David Murphy. I'm a urologist here at Virginia Urology. I've been here since 2001. I do general urology with a special focus in kidney stone treatment and prevention, as well as laparoscopic kidney surgery. I always knew I wanted to be a doctor for some reason. I wanted to help people. I didn't have any medical background in my family, but for some reason I always knew that's what I wanted to do. So I did my training up north, eventually went to medical school at NYU. In medical school, I knew I wanted to do one of the surgical subspecialties. I rotated through urology, and the minute I did it, I just fell in love with it, with the urologists and the patients, and then I went on from there to do residency and fellowship. The thing I remember is the relationship that the urologists had with their patients. A lot of the surgical specialties would be you do the procedure, you might see them in one post-op visit, and that was it. The thing that really struck me about urology is these were patients that they knew their first names and their families, and it was really a relationship. They'd see them yearly or however long, because a lot of our disease processes need to be monitored indefinitely and can recur, so we form a relationship with our patients. So after I came out of fellowship, I was specialized in laparoscopy and kidney stones, and I really thought I wanted to go into academics. And geographically, I wanted to be on the East Coast because we had family all along the East Coast. So I was looking at academic centers, and then I heard about Virginia Urology. One of my co-residents actually signed here shortly before I did, and I found that I got everything here that I'd get in an academic center. There's all sorts of subspecialties were covered, and so for me it was a great fit because I could do what I specialized in almost similar to an academic setting. So I think the great thing about our practice is we have every subspecialty covered. For the most part, we all do general urology, so the bread and butter stuff we all deal with, but then we have all sorts of different subspecialties for the stuff that may be a little more complicated, so we don't have to send people to a big academic center. We have people in our group who have just as much experience in whatever that disease process may be. So I'm very comfortable when it gets to the point that it's beyond my comfort level of sending it to one of my colleagues who has more experience, and then the opposite is true. So I think we all work very well together in that way, and I think from a patient standpoint they can be comfortable that if they come in, they're going to ultimately get the best care they can, and if needed, they'll be steered to the person who has the most experience. One of the things I always try to remind myself is to put myself in the patient's shoes. Things that to us may seem very straightforward, it's very clear what the patient may need done, and it's tempting to just tell them that, and I think I have to, and a lot of us have to take a step back and put ourselves in the patient's shoes who doesn't have the knowledge base we have, who's coming in with a lot of anxiety at a very vulnerable spot. So I try to take as much time as I can to make sure that they're on board with understanding what we're doing and address any questions or anxiety or concerns they might have. It may be something as simple as a vasectomy or a kidney stone, and something you may not even have thought was such a big deal, and then you later get a note or a letter from a patient just how much you meant to them, and they were in a crisis in their mind, and you really saved them. So that kind of stuff makes it all worthwhile.